So I entitled this, what does it take to diagnose Alzheimer's disease? And I thought we'd start with a little quiz. So first I'll turn this on. So this is just a true and false quiz. And you don't have to shout your answer, you can do it silently. But we'll see how everybody can do. So the first question is, we have a test that can diagnose Alzheimer's disease with certainty. That's true or false? Okay. So the next question is, amyloid protein, which is the protein we think is certainly involved in the cause of Alzheimer's disease in some way. So amyloid protein in Alzheimer's disease can only be recognized at autopsy. Okay. Okay, here's the third one. We can predict who is likely to progressively decline in those with mild memory problems. So the people who are starting to have memory problems, do we have a way that we can actually predict which of those are going to progress over time? Aha, at least there's one that we might talk about. Okay, so here are the answers. So it is false that we don't have a test that's 100% diagnostic of Alzheimer's disease. However, as we'll talk about, we now can recognize amyloid protein in people who are living. We don't have to wait till they die. And it's true, we can actually predict with pretty good certainty who is likely to progress in people who are just starting to have mild memory problems. Now, probably to start a discussion like this, the question comes up, is it really important to diagnose Alzheimer's disease? That is, is going through all the motions of getting blood tests and scans and seeing doctors and all that, does it truly make a difference? And I would actually submit that it does for a lot of different reasons. These are some of them. One is that not everything is Alzheimer's disease. So people have other things that cause memory problems. Many of those other things can be treated or treated differently. Second is, even if it is Alzheimer's disease, most people think the earlier you start treatment, the better the outcome. That is, that you can, even though we can't cure the disease, it's going to progress even with treatment, the treatments we have now. We can actually keep somebody functioning at a higher level longer. And that's huge, particularly as many of you know as caregivers. The third is there is an opportunity to participate in research. Probably many of you know here at the center we actually have 2 studies to prevent Alzheimer's disease. And we have a couple studies in people with the mildest form of it. And it seems, at least if we really want to change the disease trajectory of the progression, we have to start early. So the earlier you can pick it up, the more likely you're going to be successful in treating it. And I guess the other reason is a personal one, that people can actually decide their own fate. Now, nobody likes to get a diagnosis of Alzheimer's disease, that's for sure. But if that's the case, that person actually should have the right to decide what they want with the rest of their life. And an early detection will allow that to happen. However, there are challenges in recognizing Alzheimer's disease early. And one of the challenges, I think the biggest one even for us in the clinic, is that the initial symptoms of the disease are very subtle. And many people have a lot of problem figuring out, is it just part of getting older when you forget where you put your keys, or you can't remember that person's name, or you walk into a room and kind of wonder, why did you go in there? So is that the start of Alzheimer's disease, or is that just getting older, or being on sleep medicine, or other reasons? So even for us that becomes difficult because these early symptoms are very subtle. And I'll show you some information about that in a bit. The other thing is social graces, your ability to interact publicly, usually is pretty well retained. So in our medical system, when you go to your primary doctor and you have at most 15 minutes, at most, to see the doctor, and they have to go through your high blood pressure and diabetes and all these other things. Superficially, if you talk to someone, they may seem completely normal. And it's unless you really start testing or digging, that you'll see that there's a problem. One barrier, I think, for all of us as a society is this kind of stigma of Alzheimer's disease. That is, nobody wants to acknowledge it, nobody wants to be diagnosed with it, and thus people aren't brought in soon enough often. From a medical standpoint, again, it takes time to diagnose Alzheimer's disease. And yet our system, the medical system, is of course just the opposite. It's focused on getting people through, trying to see as many patients as you can, because the reimbursement to physicians and to hospitals and such is just going down. So people have to just see more patients. And then, as we talked about in the quiz, there is no definitive test. So unlike for diabetes, where you can just do a blood test, or cholesterol, or some of these other things where you get a test and you either have it or you don't. We don't have that yet, although we're getting pretty close, and we'll talk about that as well. There are certain scenarios that also are difficult too. One is people who develop symptoms of Alzheimer's disease when they're young. Young, when I say young, I'm saying like under 60. That's young. Because that's not a common thing. Alzheimer's disease, as you remember, really starts to take off, at least in the symptoms of it, once people reach 75 and above. So the older you get, the more likely it's going to happen. But it's not likely to happen when you're 60 or 55 or 50. So if somebody has symptoms at that age, then it becomes, because that's unusual, so that becomes more difficult. Or if you have presentations that are not classic for Alzheimer's disease. So you can read all the books of kind of what's a typical presentation. Not everybody follows that. And that can be difficult. The other thing that we're really learning about a lot now, as we're doing studies following older people over time, and most of you know this already, as you get older, it's not just one thing. It's never just one thing. So it's oftentimes at pathology, when you start looking at brains, a person may have Alzheimer's changes, but then they've also had a couple strokes. Or their thyroid may be low, or they may be depressed. So there's a couple things going on, and then you're left with trying to tease out, well, is it Alzheimer's disease and depression? Is it Alzheimer's disease and strokes? Is it just strokes? So it just gets much more difficult as we get older because there's more things that happen to us. So these are all the barriers of making a diagnosis of Alzheimer's disease. But having said that, there are certain groups of individuals where we have to have a higher index of suspicion. Because we know that there are certain things that make you more likely, put you at a higher risk of developing Alzheimer's disease. Doesn't mean you're going to, but just put you at a higher risk. So one are other vascular risk factors. So that is if you've had high blood pressure for a long time, if you have high diabetes that's not well controlled, if you have high cholesterol, repetitive head trauma. All these things, they don't mean you're going to get it, but it means you're at a higher risk. And thus, when somebody who has all these factors starts complaining of memory problems, then we get concerned. Certainly, if a person comes in with memory problems, that's obviously a group that we want to look into. Or if other people around them see changes. So a lot of times it's thought that if you're an older individual, you're in your 80s and you're starting to complain of memory problems, but you're functioning normally and so on, that you probably don't have Alzheimer's disease because people with Alzheimer's disease don't recognize it, which isn't true. We know, in fact, just the opposite, that as you get older, if you start seeing changes in your memory, you're probably correct, even if the doctors tell you you're not, because you know yourself better than anyone else, or you know your spouse better than anyone else, or your parent better than anyone else. So that subjective memory complaint actually becomes very important to us. And then I'll just add that people who maybe throughout their life never had any depression or anxiety, if they start becoming depressed or anxious, that's also kind of a red flag. Now, again, as you get older, there's losses, things happen. So there may be other reasons to get depressed, but still, if somebody's never been quite one who gets depressed and now they get depressed or they get anxious, that actually could be an early sign of Alzheimer's disease. So these are just some of the groups that we just have to pay a higher attention to. Again, not that means everybody has it, but they're at higher risk. So how do we make a diagnosis? So that's where it boils down to. So the classic way to make a diagnosis, a clinical diagnosis. And by the way, when I say clinical diagnosis, what we really mean is making a diagnosis based on signs and symptoms, so in the absence of having a definitive test. So there is criteria that have been set up, but this is just some of them. And it boils down to 3 components. So one is you have to have dementia, meaning you have to have memory impairment and other mental decline severe enough that it's affecting your function. That's dementia. It's really a term of severity. That's all it is. Then you have to have, so that's one, then you have to have a course that's consistent with Alzheimer's disease. So that's memory changes. Memory is usually the initial symptom in Alzheimer's disease, and probably, if you really look into it, people's judgment, their reasoning sometimes falls. They might have some behavioral problems. So those are the initial symptoms. And then over time, other things start to progressively get worse, in the absence of any physical changes. So really, in somebody with Alzheimer's disease, you shouldn't see any physical change, like problems with their balance or incontinence or seizures or headaches. That's not Alzheimer's disease. So one is you have to have dementia. 2 is you have to have a course consistent with Alzheimer's disease. And then the third part is we have to be sure nothing else that could otherwise cause those same symptoms are present. As I said, there are many things that cause memory problems, not just Alzheimer's disease. So we have to be sure nothing else is there that can mimic Alzheimer's disease. Now, to actually fulfill that, it's not really high tech. So what you need to get is just a good history. I was talking generally not only to the person themselves, but to what I would call an informant. An informant could be a spouse, it could be a child, but somebody who knows the person, who can actually give you information on how they're doing. We do some mental status testing, and I'll just show you a couple of things, well, what we do here and then some of the other ones. And then we look for these other things. So we look to be sure nothing else is going on. As far as the interview and getting a history, there are many tools that are available. You may go to doctor's offices that use this. We don't actually use this one, but just as an example of an 8-question test. I mean, or not even a test, 8-question survey, actually filled out by the caregiver spouse. And if you have 2 or more yes answers on this, then it's very likely that the person may have Alzheimer's disease. So just a very simple test like this this won't pick up people very early in the disease, but just an example of a tool that can be used. There's several different types of tests that we use in the office to test memory. So some of these you'll hear about. The MMSE, Mini Mental State Exam, is a common one. We actually don't do it here much, and I'll tell you why in a minute. But it is commonly used. It's often used to screen for studies, for research. And it's just a very simple test. It asks people their orientation, what day it is, where are they. It gives them some questions to remember, testing memory, drawing, copying a design, and so on. It takes maybe 10 minutes to do. And again, if you score low on this test, below a certain score, you probably got something wrong with you. But again, it's not going to pick up people that are early. Now, what we use here is the Mocha, and you can actually look at this online, although I would advise against it if you have a loved one who may be coming in for testing. You don't want to prompt them on it. But this is a test. It's also 30 questions, but it's just a little tougher. So it can pick up people a little earlier in the disease. So you have to start with just connecting the dots, going from number to letter. You have to draw a cube. You have to draw a clock and put the hands on appropriately. You have to name objects. You're given 5 words to remember. And then you're distracted by doing other things, repeating list of numbers. doing subtractions, repeating sentences, naming words in a minute. So it's a relatively simple test, but again, it's a little better at picking up people who are milder, have milder symptoms. So this is a screening test that we use here at the clinic. Now, again, many things can cause memory problems. So we do need to do testing to rule out these other things. And this is kind of the recommended battery of tests that we do. You don't have to remember them, but this is why when we send you to the lab, that's why we're sending you to the lab. Not that we're going to give you a blood test for Alzheimer's disease, but it's really to rule out these other things that can mimic Alzheimer's. So a blood count to make sure you're not anemic, looking at your blood sugar, make sure you're not diabetic, looking at your vitamin B12 level, which if it's too low can cause memory problems, your thyroid, making sure the function's normal, and then some type of imaging of the brain. Now again, if you can do an MRI scan, so in other words you don't have a pacemaker or something that precludes it, the MRI scan is probably the standard test to do. And I'll show you some of the advanced stuff we can do with MRI in a minute. So this is the battery that we do. And we can rule out a lot of different things. I'm just going to show you some examples. So this is what we call vascular dementia, or really dementia due to multiple strokes. And the strokes in here are these little white patches. So if you've seen the scan of even a loved one or your own, those are the things we'd be looking for. Those kind of white matter changes. So that's multiple strokes. Then there's a condition called normal pressure hydrocephalus. So hydrocephalus is water in the brain. And we all have water in our brain. It circulates through, it flushes out stuff. But it's normally about this size. It's this black area here. But you can see here somebody who has hydrocephalus where, in some sense, the plumbing system has been blocked up. So normally it continues to circulate. So in this case, at some point, there's a block. And it backs up. And so it can cause memory problems. It can cause incontinence. It can cause balance problems and walking problems. Now, actually, this isn't common, but it's totally reversible if you do have it. So it's important, it's just important to rule out. Lewy body disease, in some sense, is like Parkinson's disease. And in many of its features early on can mimic Alzheimer's disease. But it has some different symptoms, hallucinations very early in the disease process, mild Parkinson features, sleep disturbances, where people act out on their dreams. We actually even have a test for that. It's called a DAT scan. But again, it's one of the conditions we want to be sure to differentiate from Alzheimer's disease, because the treatment may be a little different. Prion disease or Creutzfeldt-Jakob disease, that's like mad cow disease. Now the good news on this one is it's very rare. 1 out of 1 million people is how frequent it is. But it's a rapidly progressive dementia. It can actually progress from somebody being normal to death in 6 months. So it's a very, very aggressive disease, but fortunately not that common. Then I'll show you kind of another interesting condition. We call it frontal temporal dementia. This affects younger people in general. And again, younger, I'm talking about onset in a person's 50s, maybe early 60s. It's unusual for this to start when somebody's like 80. But you can see on this PET scan how different it is than Alzheimer's disease. Now, PET scanning, just to remind you, is a test of brain cell activity. So what you do is you inject some sugar that has a tracer in it. And we know that brain cells use sugar for their energy, for their metabolism. So you inject it, you have the person sit there for about 40 minutes, and then you image them. In Alzheimer's disease, we see a decreased activity. So the way it's displayed is that the warmer the color, the more activity. So you could probably see even from the back. Back here, you're losing this kind of yellow-red color. It's starting to become almost bluish. And that's a typical picture for Alzheimer's disease. On the other hand, in frontal temporal dementia, it's totally the opposite. Here, the decrease in activity is all in the front of the brain. And so this PET scan can help us differentiate the two disorders. And you can see they're just entirely different. Now, if we do this type of testing, there are certain limitations. If you fulfill that criteria that we just discussed, so you have dementia, you have a course that's consistent with Alzheimer's disease, and we're sure nothing else is going on, we are going to be right most of the time, 90+%. The problem is, well, twofold. One is, if you don't quite fit that criteria, you still could have Alzheimer's disease. So 40% of people who by that criteria were said not to have Alzheimer's disease, at autopsy turned out to have it. So it's just not good enough. And then the other problem is if you buy the fact that early treatment matters, here we have to wait till somebody becomes demented. That is, they have to get to that severity before we can diagnose them. And for a lot of people, the thought is that that may be kind of late to start doing some of these more aggressive treatments. So because of that, we've kind of changed our paradigm about diagnosis. So now I'm going to move to kind of what has been the case in diagnosis to what kind of the future of diagnosis is, and it's actually starting now. So really the basis of this paradigm shift, the way we see this, is our understanding of the disease. And for those of you who've heard my talk before, it's the same slide I always show, because it's such a fundamental change. It's been such a fundamental change in our field. And that is that Alzheimer's disease begins in the brain a decade or more before you have symptoms. So the disease starts here, and gradually over time you start depositing this amyloid in the brain. And then at a certain point you do get mild symptoms. And so these are the mild symptoms that you're forgetting people's words and names and things like that. And then eventually that progresses till you get to dementia. But if you can see, and this is kind of schematic, but the dementia phase is actually probably the last third of the disease, if you look at the disease process in the brain. So what we really want to do is kind of work our way back and be able to pick up people earlier. So to do that, there have been new criteria that have been proposed. And again, this isn't anything to remember. This is really all for research at the moment, but it's just to indicate how we're going about this. So I will say this, even the research criteria still require you to have some symptoms. So even though people are now thinking about diagnosing Alzheimer's disease even before you have symptoms, I think most people would feel that to be comfortable with the diagnosis, the person has to have some symptoms, some memory change. And then we need to have some evidence by one of our tests that are becoming available that that person may have Alzheimer's disease. And so let's go through some of those. Many of them are based on what we know of the pathology of the disease to be. So if you remember, Alzheimer's back over 100 years ago described the changes in Alzheimer's disease. And there are these plaques and tangles. And the plaques are made up of a protein called beta amyloid. The tangles are made up of another protein called tau, T-A-U. So these were recognized many, many years ago, and these are the hallmarks of the disease. And we think what happens is that amyloid, it starts from a large protein that we all have. It's called amyloid precursor protein. So everybody has that. There's nothing. But for some reason, either because you produce too much of it, or you're not good enough at clearing it out, this small fragment, this beta amyloid, starts to accumulate. And then it builds up. It starts to aggregate, accumulate, stick together, and then forms these plaques. So again, the thought over time is that you start out maybe when you're in your 50s, where you start developing or laying down this amyloid, and then it starts to injure cells, and you get inflammation, and then you get the tangles forming, and then you start getting neurochemical changes in the brain, and then you start getting symptoms. So this is a long process over time. So we want to work our way back in the diagnosis. So here are some of the potential tests that we have available that may aid us in that diagnosis. And I'll just go through some of them. So one is MRI scan. Now this we do here. We're doing this day in and day out. And this is called volumetric MRI. So we can take an MRI scan, and we have software that can actually divide the brain up into different anatomical regions. And we can measure them. So this you could actually visually see. You don't need to measure it. But the area that we're really interested in is right here. It's called the hippocampus. And we know that that's injured very early in Alzheimer's disease, which is, of course, why people have memory problems early. So we can measure this because we know over time in Alzheimer's disease it shrinks. So you can see how much smaller it is in a patient with Alzheimer's disease. But early on, you can actually measure it and detect changes to a few millimeters and detect that change over time. And we believe that that may be a tool, if you're starting to show decreased volume in your hippocampus, that may actually be an indication that you're developing Alzheimer's disease. This actually is a projection of a patient over 12 months using the volumetric MRI. So it starts out this size, and as we go on over time, you can actually see the shrinkage. The shrinkage here is just indicated as the brain starts to get bluer. That means it's getting smaller. And we can actually measure that over 6 months, 12 months. You can detect that change in that short a period of time. So we have this technology now. And if you get a scan here, you will get that technology. The other technology that we have is through PET scanning. Now, I just told you about the PET scan that we use that looked at brain cell activity. Well, there's actually another PET agent. So instead of injecting sugar, you can actually inject the dye, basically a dye that attaches to amyloid. So you inject the dye, have the person sit there, and then you image them. And areas where there's amyloid and the dye picks it up, you can actually see it. So again, here's a normal, we call it control, but here's a normal brain. The warmer the color, the more activity, the more amyloid. Normal brain, Alzheimer's brain. So you can see a clear difference. One is loaded with amyloid, and one is not. This just compares the regular FDG PET, which is the one I showed you before, the brain cell activity. And again, you can see the decreased activity here. But we know, again, this amyloid builds up years before you have symptoms, and it gives us a potential way to identify people who are at very high risk of progressing. Now, you would say, well, isn't that a diagnostic test? I mean, what else causes amyloid to accumulate in the brain? And the problem is that we know if you just take randomly 180-year-old plus people off the streets and do PET amyloid imaging, about 30% will have amyloid in their brain, who are normal, I mean, not having any symptoms. What we don't know yet is if we followed those people over time, over the next 10 years, would they all actually get worse? So we don't know that. So I guess what the bottom line is, we really don't know if everybody that has amyloid, at least after a certain age, is going to get worse. However, we kind of know the opposite. If your scan is negative, if you don't have any amyloid in the brain, we could confidently say your symptoms at that time are not due to Alzheimer's disease. Because if you're having memory symptoms and your scan doesn't show any amyloid, you don't have Alzheimer's disease. So we're pretty good at ruling it out. With a scan can actually rule it out. If it's positive, it does mean you're really at a high risk, and you probably have it, but we can't say that definitively yet. So there's just, I don't want you to think it's like a definitive test. But it can be very useful. We're using it in our studies now of prevention for Alzheimer's disease. We're using it to pick out people who are at the highest risk because we're treating them with drugs that get rid of amyloid. And I think if these studies are successful, that's the way things are going to be done. If you have a family history or if you're having mild symptoms, maybe you'll get your PET amyloid imaging, and if it's positive, you'll be treated before you have any symptoms. Now, there's another way to look at amyloid, and this is in spinal fluid. And it's probably not as commonly used because nobody likes to get a lumbar puncture, which is how we get the spinal fluid. However, it's also a very good test. So this is just shows kind of levels of, well, both amyloid and tau, the other protein, in controls, normal people, and people with Alzheimer's disease. And you can see there's a clear separation between the two groups. So in Alzheimer's disease, actually the spinal fluid amyloid is low. Now why is it low? Well, nobody knows, but the usual explanation is it's low because it's being deposited in the brain. So the normal amyloid that you're clearing out of your brain all the time doesn't get cleared out, it just sticks there. So the levels get low. On the other hand, tau, which is a marker of cell injury, goes up. So if your tau is up and your amyloid is down, that's pretty predictive of Alzheimer's disease. In fact, we can predict who's going to get worse. And this is just a study where it's maybe a little difficult to interpret this, but what's happening here on this is we're looking at people who have a normal spinal fluid in the blue and those that have the low beta amyloid and high tau. And this is a group of people who start at time 0 with mild memory symptoms. So they do have symptoms, but it's mild, they don't have dementia. And we're trying to determine does the spinal fluid predict who's going to get worse over time. And you can see, if you have normal spinal fluid, if you have memory problems, but your spinal fluid, amyloid and tau is normal, the likelihood over 5 years of getting worse is very low. Maybe a percent or two, very low. On the other hand, if you have abnormal spinal fluid and you have mild symptoms, the likelihood that you're going to progress, that is have more and more symptoms progress to dementia, is very high, almost everybody. So in some sense, we can actually predict who's at the highest risk or likely to get worse. Now again, you don't get worse not everybody gets worse over a year or 2 years. I mean, this is down the line. But we do have that ability. Again, it's a reason why there's so much emphasis now on trying to detect people early and find a treatment that we can do early. So I'm just going to wrap up kind of the formal part of this, and then we'll leave it for questions. And I think these are the take-home points. So one is, it is important to diagnose Alzheimer's disease correctly. There are other things that can cause memory problems. Alzheimer's disease can coexist with other things, some of those which are treatable. So going through any of the testing that's needed is worth it. To make what you want to come out with when you go to a physician is a diagnosis. Not that you have dementia, not that you're getting older. You want a diagnosis. The second, as you can see, we have tools that are here now that we're using that can improve the diagnostic accuracy and identify people early. So nothing's 100%, but if you employ some of these tools, we get pretty close, and we can actually pick up people maybe even before they really have significant symptoms. And as I mentioned, I think there's evidence suggesting that early treatment, maybe these drugs that get rid of amyloid, may be able to slow the progression of the disease, actually slow progression of the disease, which we don't have now. So I'm just going to stop here and then maybe leave the rest of the time for questions that you all might have about the diagnosis or I guess anything else. And I'll take questions here, but maybe Susan, should I take from Elko or any of our remote sites? Do you all have any questions?
Elko, there was one question. When you had the slide up with the original amyloid cascade hypothesis showing the normal, how it got all the way down to dementia, they were wondering if chelation, if you gave it to them at the time they were really healthy, would that help clean out the brain and keep them more healthy? Yeah, so I guess you all probably could hear that, but the idea is if we know that this process is going to take 20 years, are there things that we can do at the front end, chelation or whatever, to slow progression? And in some sense, that is the idea of the anti-amyloid drugs. So chelation, which has, I think, been applied more to these metals and toxins in your system, that we don't believe is involved in Alzheimer's disease. But the same idea, that is using maybe a medication that can get rid of amyloid, that can attach to amyloid, and your system gets rid of it, your immune system, that's the approach that people are looking at now.
some of you have heard that there's one of the companies, Biogen, just published their information about a trial that they've had some success with. Again, that's all preliminary. We're doing a trial with solunazumab, which is that's a Lilly drug. There's crenazumab. So there's a number of these anti-amyloid drugs that are being tested now with that same idea. If you can get that amyloid out early, you may be able to then prevent that cascade from occurring. Any other questions from the remote sites, and then we'll take our sites.
What is your question? Do we know what normal amyloid, what it's for?
Yeah.
What it does for us?
Yeah, so the question is, what's amyloid do for us anyway if we all have some of it? Well, we don't know for sure that amyloid precursor protein, we think, has some role in nerve repair, so cellular repairs. And we think this because if you have head injury and such, you can actually see a rise in amyloid, this precursor protein, kind of in response to injury. It may have other purposes too, but we're not sure. Now again, with all proteins in the body, what happens kind of naturally is that the protein is formed, and then you kind of break it down, and then you form a new one, and then it's broken down over time. So we all produce these little amyloid fragments, but we also are normally able to just get rid of it, because we produce very small amounts. So again, in Alzheimer's disease, the thought is that those little fragments, either we're not able to clear them out as well, and so they build up, or probably genetically some people just overproduce them. They just produce an abundance of it that we can't, and then you can't keep up with the clearance. But I think the thought is the amyloid precursor protein may have some role in cellular repair. That's about all we can say. We'll take some here then. Yeah.
When a previous discussion, they showed new treatment, and they gave 4 new treatment words, all ending with the same SUV.
Yeah, SUDAB, yeah.
And I was wondering, is that Xolair? All of those are a part of Xolair?
Well, the question has to do with these drugs that are being tested. They're all in the same category, but they're all different. But these are what we call monoclonal antibodies. So it's using your immune system. So keep in mind that actually, if you really have very sensitive measures, we all have antibodies. Our immune system have antibodies against amyloid, against that fragment. It's just that we produce so little, it can't get rid of the stuff that's being deposited. So we can now artificially make antibodies against amyloid, and that's what these products are. They just vary a little different. So solunazumab, crenazumab, all these are monoclonal antibodies. They're all in the same family. They just probably are tweaked a little differently. And we don't know if they'll all be successful or just certain ones will be successful. The problem is many of you who have been in some of our studies, like the prevention trial with solunazumab is a 3-year study. So we're not even going to know what the result is for 3 years at the best. So it just takes a long time to sort this out. But I think there's enough preliminary evidence that they may be successful.
Because I've been given Xolair for hives.
Yeah, no, these are not, so no, this isn't Xolair. These are actually medications you have to inject.
So it's fine.
Yeah, but this would be, I don't think it's the same one, because these are not on the market. None of these at the moment. Yes?
Thank you very much for the explanations. It's the best I've ever heard.
Oh, good. Okay, thank you. Yeah.
But my question is, a person comes in with cognitive impairment, and everything leads to the fact that you diagnose as Alzheimer's, and it follows the same pattern. Could it be hydrocephalus or Parkinson's or caused by cancer or anything like that?
So the question is, so if you have somebody, if you have kind of now correct me if I'm wrong. So if you have somebody who's gone through the testing and has a course that's similar to Alzheimer's, could it be something else? Correct? Yeah. Well, likely not. I mean, that is if almost by definition to make the diagnosis, we have to be as certain as we can that it isn't anything else. Now, can you be 100% certain? I mean, it's never 100%. But yeah, I think with the testing that we have now, we're pretty good at ruling out other things. Certainly the hydrocephalus. and other inflammatory diseases of the brain and so on and so forth. So that's not to say we miss sometimes, but I think my feeling would be if somebody has gone through the evaluation with the blood testing and the imaging, maybe some of these more sophisticated tests, I would probably stop there. I mean, I would be comfortable that that's probably the best you're going to do.
Well, my follow-up question would be, do any of these other things follow the same pattern
Yeah.
as dementia?
Yeah. So yeah, I see what you're saying. So the question is, how much do these other things mimic Alzheimer's disease? And they can mimic. Some of them can mimic it pretty close. Lewy body disease is an example. That's a tough one sometimes to differentiate. Or even frontal temporal dementia can sometimes be difficult because the symptoms can overlap with Alzheimer's disease. And although each disorder really has separate characteristics, there's just too much overlap. So yeah, it can be confusing. But I think again, if you've gone through the testing and really get a good sense of how the course has been, we'll be right most of the time. Most of the time. Yes?
If there's, you didn't really, none of your, the presentation didn't really talk about genetic.
Mm-hmm.
But, so if my mother had Alzheimer's disease, does that make it more likely that I will?
Yeah, the question has to do with genetics. And so if you have a parent with the disease, are you more likely to develop it? And the answer is yes. I mean, that's the short answer. If you have a family history, that is a parent or brother or sister, you're at a higher risk. But it's just, we're talking about risk. Doesn't mean you're going to. It's just you're a higher risk than if you didn't have that. There are, and I didn't mention it, which would probably be an omission, there are genetic tests that we can do also. It's not the common thing we use in the diagnostic process, but sometimes they can be helpful. There's a gene called ApoE, and we all have ApoE, and it has several forms just that occur naturally. They're just numbered 2, 3, and 4. So if you carry E4, you're at a higher risk, and that can be measured. You can use a blood test to do that. The problem with that test, again, it just tells you your risk. It doesn't mean that you're going to get it. It just means you're at high risk. So we generally don't do that genetic test. There are rare families where the disease definitely runs. I mean, you can see it generation to generation. Now, usually it starts at a young age, and we can actually test for some of those genes. And in those situations, if you carry that genetic defect, you will get the disease. That's 100% predictive. But again, those families are very rare, and the onset is, again, when you're in your 50s, young, 52, 53, not when you're 70 or 80. So genetics are important. We don't use them routinely in a diagnostic sense, but yeah, if you have a family history, you're at a higher risk. Yes?
My 98-year-old father lives out of town, and I don't know if he has Alzheimer's or dementia. I don't know if he's been tested for it. Would this informant interview be something I could converse with him over the phone in a non-threatening way, or should I ask his doctors to test him?
Well, the question has to do with, yeah, if you're caring for somebody at a distance, how do you get that diagnosis made? Well, I think the informant questionnaire, so it is something that right, you would fill out with your observation or information from your father. And it will give you some sense of what's going on. But it's, at some point or another, yeah, he would have to be evaluated by the physician anyway. That would be the starting point. Now, again, it's kind of an interesting point. You mentioned he was 98, and so the question comes up, and I'm actually very serious about this. The likelihood of being completely normal when you're 98 is I mean, mentally, is very low. It's not zero. I mean, there are some people who are 98 and 100 who are okay, but it's just that, the older you get, the more it's just the higher the likelihood you're going to have some memory changes for some reason, whether it's small strokes. It doesn't have to be Alzheimer's. It could be Alzheimer's, small strokes, medications you're taking, whatever. But if he's otherwise functioning okay, then yeah, it's worth, even at that age, taking a look, because it may be something you could tweak and improve. So, yes?
I was watching 60 Minutes, it was last year sometime, and they were evaluating older patients. I think
Yes.
it was for dementia. One of the questions they asked, I have two parts. One of the questions they asked was, they had them spell world backwards. What's the relevance of being able to do this or not being able to do it? And what if you can see it in your brain going forward, but then when you try to spell it backwards, the letters disappear?
Yeah, so the question has to do with basically screening tests for memory disorders or for cognitive disorders. And so the example is world. So, can you spell it backwards? So the relevance of it is just a screening test. I think there are many other things you can do. There's something called a mini-cog, which I had listed, which is a three question test, or 3 parts. So everybody's looking for something you can do really quickly, just to kind of get a screen to see if something's wrong. So, and I think the idea is, you're right, spelling world backwards takes, well, first you have to spell it forwards, but if you can spell it forwards, then going backwards is a challenge, because you have to either visualize it and have the concept to switch it around, and you have to keep it in your mind, which is working memory. So even that very simple task involves a lot of work, memory work, even though it seems really simple. So I assume that's why, again, they're just looking for something very simple you can do just to kind of get some idea. So in other words, if you could spell it backwards, it doesn't mean you're normal, but if you can't spell it backwards, then maybe you should have further testing, something like that. Whether, if it goes away when you flip it, that could be from a lot of different reasons. But one of it's primarily a test of we call working memory. And working memory is where you have to put something in your mind and manipulate it. It'd be the same thing as if I gave you a set of numbers and I said, now I want you to repeat them back to me in reverse order. Because you have to remember them forward, but I gave you forward, and then you have to manipulate that and get it turned around backwards. So this is working memory, and working memory is affected relatively early in Alzheimer's disease. So these are just kind of screening tests, simple screening tests. Yes?
Why do women seem to have the propensity to get Alzheimer's over men?
Yeah, so the question is, why are women more likely to get Alzheimer's disease versus men? And nobody knows. If women are more likely to get it, it's not by a huge amount. So there are a number of epidemiologic studies, that look at whole groups of people, and some of it's a little conflicting. But I think maybe you can kind of buy the fact that women are a little more likely, maybe related to hormonal differences. People thought that was the estrogen issue. That's why there was actually a large study of estrogen in women, postmenopausal women, which by the way was negative, of course. So it's not recommended that women go on estrogen, certainly not for memory, to help your memory. But nobody really knows why that difference is, and really how real it is. And by the way, that's not just because women live longer, because they factor that in. It's still women kind of come out a little more likely.
Would you differentiate between dementia and Alzheimer's?
So the question is differentiating dementia and Alzheimer's. And again, one is dementia is just a term of severity. So we just use it in describing the severity of somebody's memory loss. So it's got to be severe enough that it affects their function. So that's dementia. Alzheimer's disease, as I mentioned, you can have Alzheimer's disease and have no symptoms. It's a disease process in the brain, and that goes from no symptoms to dementia, but it's actually a specific disease. So kind of the bottom line is a lot of things can cause memory problems severe enough to affect your function, or dementia. Alzheimer's, strokes, Parkinson's disease, blah, blah, blah. So it's really just a descriptive term, the Alzheimer's, the dementia. Yes?
If your mother, your aunt, and your grandmother had Alzheimer's disease, and you think that you're a dead ringer, what can you do ahead of time to prevent the symptoms?
Yeah. So this is the question is, if you have a family history, is there anything you can do to reduce your risk? And I will mention that we'll be rolling out here something called the Healthy Brain Registry, which is actually focused on that very issue of trying to enroll individuals who are at risk and aren't, and actually provide information about healthy brain aging and periodic testing that you can do on yourself and so on. This will all be online. So we'll be rolling that out pretty soon. But I think that there's 3 major areas of lifestyle interventions that people talk about. The most important probably is exercise, physical exercise. And there's just a lot of information about the role of physical exercise and brain health. And it's not because you're increasing your blood flow to the brain. It's not that. It's actually you produce chemicals in the brain that are protective. At least animals do. And so the physical exercise, probably number one. The second is diet. And people talk about diets that are rich in antioxidant foods. So green leafy vegetables, berries of all type, dried fruit. These are all things that have a lot of antioxidants in them. If you're looking at a type of diet, you know, oftentimes people equate it to a Mediterranean diet, although, you know, it doesn't have to be that. And then the third is kind of this idea of mental activity and social engagement. So, you know, just kind of being in there, where you're still keeping your mind active and trying to continue to learn. I mean, you're all here because of that. So those are the three things people talk about. Now, how much does each one help you? Hard to know. But even a little effect over a long period of time becomes a big effect. So I think these are things that are probably worth pursuing, along with, and the final thing is, if you have risk factors, those cardiovascular risk factors, high blood pressure, diabetes, those things, you got to jump on them when you're in your middle age. You can't wait to you're older, because those two accumulate over time and put you at a higher risk. So those are probably the only things we know. Taking supplements or doing these kind of things, there's no evidence at the moment. Yeah. Yes?
Dr. Burdick, is there any plan to start researching it much younger, 40 possibly, since stop disease starts 10 years
right.
later than we realized, and start getting that library of information available?
Yeah. So the question Laura had was, you know, should we really start examining people not when they're 70 or 80, but when they're 40 or 50? And I think there are studies that are doing that. The Framingham study, for example, which is some of you may be familiar with. This has been following a community in Massachusetts for 50 years, or actually I think they're on the third generation, trying to get some sense of really how things evolve over time. It's a difficult thing to do just practically, because we know that 40 or 50-year-olds aren't going to show many symptoms, and you're going to have to follow them over a long time, and it costs a lot of money, and so a lot of it is just a logistic things. But in truth, that's where you really would want to start looking, because that's probably where the action is when you're 50. Not that's when things start, probably not when you're 90 or 80. Yes.
I have an older sister and a younger sister, and they both have dementia, and I imagine pretty close to Alzheimer's. I'm the middle one, and so far I haven't had it. And I am 89 years old.
There you go. Good for you. Yeah, very good.
Yeah. So I don't know that I'm more social than they are. I know I have always bought better food than what they did. And I read a book probably every week.
But there you go. So you're an example of again, healthy aging. But keep in mind again, but you bring out the point of, again, genetics is just one component. And even if you have a parent who had the disease and a sister that had the disease, your chance of inheriting the genetic marker is still 50-50. So, this is all kind of just a random thing. That is, you could have somebody who has a parent with the disease and all the children get it, or you can have a family that has a parent with the disease and none of the children get it, because each child has a 50-50 chance of inheriting the gene. And then there's probably other factors, which you talk about, diet and exercise and keeping your mind active. So, I think if you have a family member with the disease, as I do, again, it doesn't mean that's your fate. But you're at a higher risk, so doing something about it sooner is probably better than waiting.
But our mother and father never had anything, and my mother lived to be 90.
Yeah, so again, it brings up the same issue of genetics is one factor, but there may be other factors that contribute to that, maybe diet and other things. Yes, you have a question?
Yeah, my mother was 90 years old when she died, and she was in the habit of doing crossword puzzles. And I wonder if that helped them keep a brain healthy.
Yeah, so the question is, you know, things like crossword puzzles, are those things useful? Is it worth doing that? And all we can say is that people who are mentally active do have a lower risk compared to people who are not as mentally active. But that's all we can say. We don't know if it's because they do crossword puzzles, or do they do crossword puzzles because they are healthier, and you know, so we don't know the causation. But certainly, I think that's the recommendation: is to stay mentally active, and whether it's crosswords or a Sudoku or reading or learning a new musical instrument. I'm not sure there's one specific plan, although I'll make a plug here, because we do have, for people who are starting to have memory problems or may have early Alzheimer's disease, we do have a cognitive training program that started here through our occupational therapist to actually get exercise, just like you do physically, to exercise your brain. So people are looking at that as a way to treat.
And Ruvo mentioned that one of the first things you look for is injury to the hippocampus. What are the causes of injury to the hippocampus?
So the question is, why is the hippocampus affected early in the disease? And we don't know. We don't know why that structure is so susceptible to whatever the disease process. Actually, the hippocampus is very sensitive to a lot of different things. It's sensitive to lack of oxygen, so people who've had cardiac arrest, that's why they have memory problems, or other low blood sugar. So it seems like just a very sensitive, the cells in that structure are very sensitive to injury. And for whatever reason, that's kind of the marker of early changes in Alzheimer's.
So could a fall, even though the fall hasn't hit the head, could a rather severe fall cause injury to the hippocampus?
The question is, could a fall cause injury to the hippocampus? And it would have to be pretty severe. It'd have to be pretty severe to do that. So Susan, are we out of time?
Yes, we're out of time, but I think Elko has her
good.
finger on the button.
Okay.
One quick, as long as you're talking about the shrinking hippocampus, when that shrinks and that black area is around it, is that amyloid, is that where the amyloid stickiness is, or is it just empty space, or what's around that shrinkage?
Yeah, so the question is, you know, when we show that small hippocampus, you know, what's that area around it? And that is space. It's just, well, it's fluid that's taken up the space. So, and that's true of the whole brain, by the way. As the brain shrinks, what happens is the fluid takes up the space. And so those black areas around it is really just fluid that's been produced and just takes up the volume. Something has to take up the volume, and it's that. The amyloid, by the way, is within the brain, and that you can only really see at a microscopic level or through the imaging. There's no way on a regular MRI scan you could see amyloid.